Okay, then I'll start. Let's see here. Hello everyone, my name is Trine-Lise Hannevik. I'm a PhD student at the Department of Hematology at Akershus University Hospital in Lørenskog. That's about 50 minutes drive from Oslo in Norway. Thank you so much for letting me present on this journal club today. Especially thank you to the International Cardio-Oncology Society and Stephen, who was patient with me in testing a few days ago. In my PhD project, I work with venous thromboembolism in cancer patients and anticoagulants. But for today, I chose an article on cancer patients with atrial fibrillation and the difficulty of choosing anticoagulant treatment for these patients. My PhD program in our trial, we have received an unrestricted grant from Pfizer, but I have no personal disclosures. So this is the article for today, and it's on the efficacy and safety of non-vitamin K oral anticoagulants in patients with atrial fibrillation and cancer. So this is the meta-analysis. And to give you a bit of background, on average, or at least this article states that 1/4 of individuals with atrial fibrillation also has cancer. So that's quite a lot of patients. And the atrial fibrillation can be diagnosed before the onset of cancer, or it can be come as a consequence of the cancer disease, or being treatment related. When it's treatment related, it can be related to chemotherapy, radiation, or surgery. Not many months ago, some of you presented an article on ibrutinib, which is a known drug to induce atrial fibrillation. And the ESD guidelines doesn't provide any specific recommendations for at least on what anticoagulant to choose for these patients. There are not many data as to randomized controlled trials, but the guidelines states that maybe this should be a decision that should be made by a multidisciplinary team. But I guess, I don't know how many of you are clinicians and how many of you are researchers, but I was hoping maybe at the end of the presentation, if some of you are clinicians, maybe you could share some of your experience with this and what kind of anticoagulants you use when you have a cancer patient with atrial fibrillation. As far as I can see, there are no randomized trials assessing this this population for anticoagulant treatment. So guidelines, they rely on pooled analysis of data, both from RCTs and observational studies. So the objectives of this study was to examine clinical data on anticoagulant treatment in cancer patients with atrial fibrillation. And I'll take you brief through the methods and how they selected their articles. The articles that was selected, they were reporting clinical outcome of atrial fibrillation in patients with cancer, and they were receiving NOACs or VKAs like warfarin. So they were both randomized and observational studies. And here you see the search strategies. These are the databases, and these are the keywords used in the search. The quality assessment of the studies, they used the Newcastle Ottawa score in observational studies and the Cochrane collaborations tools in randomized trials. So they first did a primary analysis where they studied the randomized controlled trials, and then they did a secondary analysis where they looked at the observational trials together. The efficacy outcomes for both the primary and the secondary analysis was as stated here. Composite of any stroke or systemic embolism, ischemic stroke, venous thromboembolism, and the safety outcomes was bleedings. And major bleeding was major bleeding was like the IST age description, yeah. And then they looked also at intracranial bleeding, gastrointestinal bleeding, and all-cause death. And all the results was presented as odds ratios with 95% confidence intervals with a p-value less than 0.05. So these are the search results, and I'm going to present the articles that was eligible for inclusion. So the first three here was a 3 post hoc analysis of randomized trials, and maybe many of you know these trials. The Rocket trial, which assessed rivaroxaban versus VKA for treatment of atrial fibrillation. Aristotle, which assessed apixaban, and Engage for edoxaban. And under here we have 3 observational studies. So you can see here for the randomized trials, these was the total of included patients in the study. Can I just say, can all of you see the mouse? Steven?
Yeah.
Yes.
Yeah. Okay. Yeah. So this was the total, and this was the amount of patients with cancer in the study. So, and this was for all the 3 studies. And so you see the main, none of the studies follow the patient for more than 2.8 years for the randomized trials and 1.9 years for the observational trials. So in the observational trials, all the patients had cancer from day 1. And here, of course, you have a few patients with cancer and a lot of patients without cancer. Let's see. So here are the results, and the first figure they present. Here they take, here's the primary analysis of the randomized, or like the post hoc analysis of the randomized controlled trials, and this figure describes all the patients from all the 3 trials. The grays are the people with cancer, and the greens are the people with no cancer. And all the patients here are on anticoagulants, either NOAC or VKAs. So you see that if you have cancer and you receive an anticoagulant, you have a higher risk of all-cause death compared to a patient with no cancer. You also have a higher risk of acquiring a major bleed and venous thromboembolism. So that can be a first venous thromboembolism or a recurrent if you had it before, but still on anticoagulants, you have a bigger risk of having a new venous thromboembolism episode. It seems from this population in this study, it seems like the risk of having an intracranial bleed or a stroke is the same, regardless if you have cancer or not. And these are the outcomes for the randomized trials in the primary analysis. So here you see that for stroke and systemic embolism and ischemic stroke, the analysis favors NOAC, but all the confidence intervals include 1. So it's not statistically significant. And the same shows for venous thromboembolism. And actually all-cause death, it looks the same. So if you use NOAC or you use VKA, when you look at all-cause death, it's the same. But of course, this is for this population and only for follow-up for 2 years. For major bleeding, it seems to favor NOAC, but still here the confidence interval contains 1 and it crosses the line. But for intracranial bleeding, it looks like NOAC has a better safety profile, at least for this population. So remember now, this primary analysis is of the cancer patients in all these three trials. Together, it's about 2,000 patients or so. Yeah. And for the secondary analysis, they analyzed 3 observational studies with quite a lot of patients. And here, all the patients has cancer from day 1. So, they compare different kinds of anticoagulants. None of these studies include edoxaban, as I can see. So these results I'm only going to present in text and numbers. As you can see, as a tendency in the observational studies, the patient that receives NOACs tend to be more protected from stroke and systemic embolism, ischemic stroke, and venous thromboembolism. The risk of bleeding seems to be at least not favor NOAC for major bleeding and for intracranial bleeding and for gastrointestinal bleeding. There is no it doesn't seem like it's better to use NOACs versus VKAs. So you see there is a difference from the primary analysis where it looked like you had a smaller risk of intracranial bleed using NOACs. So to sum up and to see what the authors conclude with this article, they conclude that patients with cancer, they have an overall higher risk of having venous thromboembolism, major bleeding, and also have higher risk of all-cause mortality even when they are on anticoagulation. And this is compared to patients without cancer. In this study and in this population, it seems like it's a similar risk of systemic embolism and stroke and intracranial hemorrhage compared to patients without cancer. And in the end, the author states or concludes that it seems that NOACs are at least as effective as VKAs in preventing thromboembolism in patients with atrial fibrillation, and maybe it has a better safety profile when it comes to intracranial bleeding. At least this is the result from the primary analysis. I would like first to say a few words about limitations, and then I would like you to invite you to a discussion of ask if the clinicians that are listening to, how do you decide how to anticoagulate your patients? But the limitations in this study is, of course, that here you don't have an access to individual patient data. So all the results are reporting as a whole group, and the cancer patient is a whole group. It's not subdivided by cancer type, stage, treatment, etc. And for the last few years, it has emerged 4 or 5 new randomized controlled trials assessing treatment of cancer-associated venous thromboembolism. And there you can see there is a difference in risk of encountering both thrombosis and hemorrhage decided by cancer type, stage, etc. So information this article cannot give us. And of course, there is a risk of inclusion bias in the observational studies and limitation known to retrospective studies as in the primary analysis. Yeah. So I don't know how many of you are clinicians, but and how many of you treat these kinds of patients in your everyday work. But can some of you state, like, how do you choose your patient's anticoagulant? Let's see. There are no clinicians here.
May I intervene?
Yeah.
I am Agnese Maria Fioretti from Bari Cancer Institute, Italy. I would like to say that it's a very challenging issue, the use of anticoagulant therapy in cancer patients with atrial fibrillation, because we know that warfarin is not a good choice because it is not safe, it has not a good efficacy, it is not practical in this clinical setting. We usually choose for heparin when it is possible, but personally, I think that the future is the use of DOACs. There are not specific trials, as you said, but also recent international guidelines, like the one from International Society on Thrombosis and Hemostasis, are in favor of the use of DOACs, especially in patients who used to have this therapy before cancer. So this is my experience and my opinion, and I agree with you that in these trials you presented, the real problem was that the definition of active cancer was very heterogeneous, and one cancer patient is different from the other one for stage, for site, for anti-cancer drug, and according also, for instance, to coronary risk score or other certification scores. So this is my point. Thank you.
Thank you so much. Do anyone have any other experiences?
Hi, this is Gita from Norway. I find this quite challenging because I think I always have a discussion with the oncologist here in at my hospital, and the discussion that often comes up is whether to use heparin or to use the NOACs because of the chemotherapies. I'm really afraid that the patients will go into a thrombocytopenia, and then they don't know how to handle that. And many people think that's easier to handle with injection than with NOACs. Do you have any comments on that?
I'm sorry, I didn't hear the last, Gita. Sorry.
If you had any comments whether it's better to use, for instance, low molecular heparin than NOACs because some of the patients have the problem with thrombocytopenia when they get chemotherapy.
I'm not really sure. I see we have another guy from Norway here, Anders Astrupdal. Do you want to comment on that?
Yeah, hello. Generally, low molecular weight heparin have shorter half time, which if the patient gets bleeding or something, it's and you also have antidote, which make it somewhat more safe. But the studies of venous thrombosis shows that they are more or less equal, it seems. But it's the shorter half-time of low molecular weight heparin and the possible of antidote that makes it somewhat safer if you have, let's say you have thrombocytes of 60 and expecting it to go lower or something.
I have a question.
Else?
Yeah. I have a question, if you can hear me.
Yeah.
All the NOACs actually are metabolized with the CPY3A4 system, which a lot of the anti-cancer drugs also are metabolized by, and we don't have a way of monitoring anticoagulation. So I think that raises a question that we really don't know how to deal with in terms of that kind of interaction. I wonder if you have any comments about that.
No more comments. That yes, it is difficult. And when you have to at least, maybe this is better with Dolteparin, that is not so many interactions as with the NOACs and especially with warfarin. But the key is like there are so many issues to consider before you choose the anticoagulant. So therefore, I think it's important that you can't treat the whole cancer population as a whole, as in this article, because the risk is the risk of acquiring all the endpoints are not similar when you see the different cancer types and the different cancer treatment that the patients receive. Yeah, so I don't have any answers other than it's a difficult decision.
I would say, as Cohen again in St. Louis, I would say again that generally, if you have a thrombotic burden, we tend to use the low molecular weight heparin first. For example, if you actually see clot in the left atrial appendage, or if you have other thrombotic issues, clot in the ventricle, in other words, where you actually have a major thrombotic burden, those you would treat with a low molecular heparin. Otherwise, with atrial fibrillation, ordinarily, we would try to make it as painless as possible with the NOACs, which work well. The biggest problem we have in the US is that some people can't afford them, and that's a major issue in some people, although the insurance companies are getting better at that.
Would you say they can't afford the NOAC or they can't afford the Dolteparin, which is
both of them? Both of them.
Yeah. Any other ones?
Different countries have different problems with their drugs. We're just listening to people in Poland, and they have very limited, it sounds like they have very limited options for many things.
So maybe where economy is an issue, then I guess warfarin is the drug that is most used because it's the cheapest.
Looks like Catherine Banfield, you had a question or comment? I wondered, Joe Carver, if you have any comment.
What was the question again, Steve?
Yeah, so that was an excellent compilation of stuff that's out there. I agree with everybody that decisions almost always are individual, based on individual patients and other things going on. But we tend to use NOACs and preferentially apixaban, since there may be less bleeding even on NOACs with apixaban compared to the other drugs that are available.
It's a bit difficult, at least for me, to hear that last comment.
This is Isaac Ray from Memphis, Tennessee. I kind of a question for the group. I've got a patient right now who his hemoglobin is kind of 7s to 8s, but he's got a CHAS vascular at least 4, and we've tried him on he bled a bit on standard dose rivaroxaban. We're moving him to apixaban, but the question keeps on coming up. If someone's at risk for some bleeding, is it better to be on a subtherapeutic dose of apixaban or something like that than to be on nothing at all if they can tolerate it? I wonder what the group thinks of that.
Hi, this is Veronica from Brazil. Can you listen to me?
Yes.
Oh, good. I'm in the pediatric field, but my curiosity is there any close future use for NOACs in a pediatric population? Have you seen anything about it? Or maybe perhaps because the only thing that we use here is the enoxaparin. So any research running in the pediatric population? Can you tell me?
Maybe if there are some hematologists who are listening, maybe can comment on that. I'm not really sure. No.
I have a comment to the previous comment that was made. This is Gita from Norway again. I was just wondering if you have a patient like that where you are thinking whether to use lower doses of NOACs than what's recommended. Isn't it then better to use low molecular heparin, because then you would have more control over the bleeding situation? I don't know what the rest of the group thinks.
Hello, so for example, this is Jose from St. Louis. At least in my experience, even in patients who have a low hemoglobin, like 8 or 7, and they're being treated for certain types of cancer, and I talked to the oncologist, and even though they're anemic, the anemia is not from active bleeding, and we have continued them on standard dose of apixaban, for example, without any bleeding complications. So I guess it depends on the cause of the anemia and if there is any concern that the patient is actively bleeding. And I would take into account the type of malignancy, if it's a GI malignancy versus some other malignancy that is not GI.
Hello, can you hear me?
Yeah.
I'm Sebastian Schmidt from Poland. I'm cardio-oncologist. I'm so sorry I was late because I had a lecture for my oncologist in my university, but I would like to confirm the opinion from Jose that in my center we prefer to use apixaban as the most safety oral anticoagulant, new oral anticoagulant. We base on the data, from example, from the Caravaggio study. We participated in this study, and when we used apixaban in cancer patients, we observed lower risk of bleeding, especially in patients with gastrointestinal cancer. So we prefer apixaban, but we know that in high-risk patients of prothrombotic activity related to cancer disease, for example, in patients with prostate cancer, or especially in patients with pancreatic cancer, we think more about rivaroxaban as the more with the more activity against thrombosis risk, but the problem with our rivaroxaban is associated with the higher risk of bleeding. This is my opinion based on my daily practice with my team. And my question to you is, what do you think about CHA2DS2-VASc score in cancer patients? Do you use CHA2DS2-VASc score in your daily practice? And what do you think about the using of new oral anticoagulants in patients with brain tumors?
If there are any cardiologists that could answer that question, usually I work with venous thrombosis, which I guess was what you meant when you mentioned the Caravaggio study, when you have your patients and you treat venous thromboembolism. Was that right? But of course, the safety profile is the same either if you treat venous thromboembolism or atrial fibrillation. But I don't know how much you use the CHA2DS2-VASc scores on cancer patients, if anyone wants to comment on that.
CHA2DS2-VASc score and also Haas blend are not measured in cancer patients. So this is a great limitation. About brain cancer, primary brain cancer has a major bleeding risk than secondary brain cancer. However, in secondary brain cancer, it's indicated by international guidelines heparin. This is my experience.
Therapeutic dose?
I didn't listen your comment. Can you repeat, Sebastian?
Sebastian. So in our experience with patients, to answer one of the questions that you had about the brain tumors, we make a distinction between primary brain tumors and metastatic brain lesions. And so far in our experience, at least in brain metastasis, we analyze the latest brain imaging, and we talk to the oncologist, and if there's a neurologist involved, then we make the decision on continuing it. And we don't use we use standard dose. For example, if apixaban 5 milligrams BID. We have been keeping track of these patients, and so far we haven't had any intracranial hemorrhage in our limited experience. There was a retrospective study by, I think, the group in one of the institutions in Boston, that they studied direct oral anticoagulants in patients with brain tumors, either primary brain tumors or metastatic brain tumors. And they found that the new oral agents did not increase the incidence of major intracranial hemorrhage in brain metastasis or in patients with primary brain tumors when compared to low molecular weight heparin. So I think that it all depends on it's a decision as a group that you make based on the how recent the metastatic lesion is or the brain tumor is, and but I think it's not a total contraindication.
Yes, completely agree, Jose. We have the same experience. The data from the literature that the new oral anticoagulants, especially apixaban, may be more safe in cancer patients with brain tumors. I completely agree. And my comment is, if you don't use the CHA2DS2-VASc score, so you decide to use new oral anticoagulants in all cancer patients with atrial fibrillation?
So, for example, in our experience, I make the decision on an individual basis. Let's say a patient has breast cancer and it's going to be on endocrine therapy as maintenance therapy, and they are 50 years old and they have AFib, and then they're on one of the endocrine therapies. So I talk to the patient and I say, hey, this is what's going on in those patients who are on endocrine therapy by themselves without history of AFib. I tend to put them at least on aspirin 81, given the risk of thrombosis. But if they have AFib, I just discuss it with the patient and I make a joint decision about this patient has a risk based on the medications they're getting plus the AFib. And if they say that they're okay taking it and they have no history of bleeding, then we give it a try.
Okay, thank you, Jose.
Oh, just to extend the discussion and make it more complete, we've had a number of patients that the question came up after gamma knife therapy, and we've not had an issue with anticoagulation after gamma knife treatment.
It's a bit difficult to hear.
Hi,
Yeah.
oh, sorry. Hi, this is Robert Copeland Halprin from Northwell in New York. Just to add on to these comments, I think I do sometimes make a distinction about what the primary malignancy is. Malignant melanomas in the brain tend to have a higher bleeding risk, as do renal cell. I think, breast cancer and lung cancer have relatively lower bleeding risk, at least in some case series that were done, at the Cleveland Clinic. So I sometimes incorporate that into the decision making. I think it can be helpful. And then in general, with these patients at higher bleeding risk, I try to eliminate concomitant aspirin with DOACs or anticoagulation, unless there's this very compelling reason. So many patients are on aspirin just because of the history of atherosclerotic disease. But if it's stable and no recent stents, there's really no need for it if they're on an anticoagulant, in my opinion.
Any other comments to this issue? No, then I just have a few slides left. This is just to illustrate that we don't have data for other patients than who is actually included in the studies. So here is from the randomized controlled trials in this study, the Maloney study. You see that most of the patients here, they had prostate cancer, and post-hoc analysis of the ROCKET population, also many people had prostate cancer. So, and a few cancer types aren't even represented here. So that's something to think about when you choose. So you can't really treat the cancer patient population as one population. You have to subdivide. This is the cancer types from the ENGAGE study. So for future direction, I will say there is a need for more randomized controlled trials assessing this problem, anticoagulation in cancer patients with atrial fibrillation. And as all of your comments really highlights that you have to subdivide in the cancer population to really give the patient the best treatment, especially so we can treat the endpoints we like and not kill the patient with side effects. So thank you very much, everyone. This is where I do my daily work at Akershus University Hospital. And when I don't work, I guess you all think that we Norwegians ski. Some of us do, but this was my only ski trip last year. So thank you so much for letting me present this article and for many valuable comments. Yeah.
Thank you so much. Are there other questions or comments, discussion?
Oh, thank you.
Thank you for discussion.
Thank you. Congratulations for your work. Hopefully we have something in our pediatric population. Thank you. Thank you.
Thank you very much. Congratulations for your presentation.
Thank you all for your participation. And next week, same time, we'll have a case review coming out of I believe from our Iraq chapter. So wonderful participation globally, and we always appreciate y'all jumping in and having good discussion. Thank you so much. From Norway, Dr. Hannevik, we appreciate your time.
Thank you so much.
Goodbye.